Good morning. We're going to go ahead and get started. Just a couple of housekeeping things. I'm just trying to get an idea who tapped into the QR code this morning. Raise your hand. Oh, it's a fair number. Good. Okay. All right. The second housekeeping thing is if you all wouldn't mind in the back sections, can you move up to the front? It's just lonely up here. I think it's hard for our speakers to give a talk when the front 3 rows are empty. So as many of you, please come on down. I wouldn't sit in the front row, then you'll get a neck ache. All right. So we have 2 great talks this morning. Dr. Kia Washington will be our first speaker. As all of you know, she's one of our leaders in the Department of Surgery. She's Vice Chair of Diversity and Inclusion. She's a professor of surgery in the plastics division. Her undergraduate training was at Stanford. Then she went to Duke for medical school, and then did the combined program in plastic surgery at Pittsburgh, and then did a fellowship in hand, right, at Pittsburgh. She was on faculty there for a while. I worked with one of my mentors, Dr. Andy Lee, who I know very well. And we were very lucky in 2018 to recruit her to the University of Colorado. She's well published, asked to present internationally and nationally, has had and has millions and millions of dollars of funding, particularly from the DoD. Runs really a state-of-the-art laboratory program, which you will hear about in a couple of minutes on eye transplantation, both the basic science of it as well as the translational aspects. She is Director of Research for the Plastic Surgery Division and has mentored many, many trainees, both in the clinical as well as research realm. And with that, I'm going to turn it over to you, Dr. Washington. Thank you so much.
Good morning. Thank you, everyone, for coming today to hear about our work in whole eye transplantation. Vision loss affects approximately 39 million people worldwide, and it's primarily due to age-related diseases such as glaucoma, but also is due to ocular tumors and ocular trauma. Our particular interest is combat ocular trauma. About 16% of all evacuated wounded service members have sustained combat ocular trauma, and it ranks 4th of injuries of all active duty members. And the biggest cause of loss of vision after combat ocular trauma is enucleation, or the need for surgical removal of the eye. Currently, there is no medical cure or surgical treatment for blindness, in particular in the setting of trauma. Recently, in the last decade or so, there has been a lot of talk about eye transplant as an option to treat, in particular, combat ocular trauma or traumatic injuries resulting in blindness. And it was previously thought to be science fiction. We've sustained major funding from the Department of Defense through the Joint Warfighter Medical Research Program to launch a comprehensive approach to eye transplantation. Eye transplantation, however, is not a new concept. In 1885, Chabray, a Frenchman, transplanted a rabbit eye into a blind girl, and it failed for obvious reasons of lack of blood supply and also immune rejection. About 100 years later, the National Eye Institute revisited whole eye transplantation through an advisory council. And they felt that at the time that there were 3 major obstacles: the difficulty of ensuring adequate blood supply to the transplanted eye, the question of immune rejection of the ocular tissue, and the failure of the optic nerve to regenerate being the biggest obstacle. However, there have been a lot of advances in optic nerve regenerative research in the last decade or so. And there's been research and studies that have shown regeneration in the optic nerve to the visual centers in the brain in small animal models after a crush injury. We also now have a lot of knowledge from vascularized composite allotransplantation, Over 100 hand and face transplants have been performed throughout the world, and they've shown our ability to reconstruct complex defects due to advances in microsurgery and immunomodulatory therapies. This is a picture showing the first double hand transplant in the United States in 2010, and I was lucky to get to participate during my residency at the University of Pittsburgh. We also now nationally have the experience from face transplantation in particular. Over 36 face transplants have been performed throughout the world, and a lot of them involve the periocular tissue or tissue surrounding the eye. And some of these candidates have actually been blind or visually impaired. This is an example of a blind full face transplant recipient. He sustained a burn to the face, and you can see on the left side is prior to the full face transplant. And you can see after he's had his full face transplant. And those are actually eye prostheses. He's actually blind. So he's an example of somebody that could possibly be a good candidate for eye transplantation, as he's already going to be receiving immunosuppression for the face transplant and already receiving surgery in the areas around the eye. So blind face transplant candidates could be ideal first eye transplant candidates, again, because they are already on immunosuppression and already receiving surgery on the periocular tissues. Thus, they have a lower risk-benefit ratio as compared to a patient with an isolated ocular injury. So our overarching goal is to restore functional vision with total human eye allotransplantation with our translational pathway from a rodent model to preclinical studies, human cadaveric studies, and the ultimate clinical translation to total human eye transplantation. Our first goal was to develop a small animal model. During the time when we started our research, there wasn't really a good animal model for eye transplantation. During my residency, I was lucky to be able to do 2 years of dedicated basic science research in the Starzl Transplant Institute. And during that time, I did research on face transplantation, where I developed a functional face transplant model on the rat. This I actually used to look at cortical reintegration and cortical mapping after face transplantation. But this model did serve as a stepping stone for our whole eye transplantation small animal model. From this model, I was able to develop an orthotopic rodent eye transplant model. And to our knowledge, this is the first model of this type in the world. This is the outline of our donor graft. So we harvest the entire hemiface with the eye. This is the underside of the flap, which includes the optic nerve and the pedicles of the common carotid artery and external jugular vein. We then perform our recipient procedure and perform anastomosis between the common carotid artery and external jugular veins, as well as we do a nerve apposition and sew the optic nerve together of the donors and recipients. This is an example of a naive eye prior to transplantation during the ischemia time, and you can see 1 hour after reperfusion. So these are some examples of our rats after transplantation, syngeneic and allogeneic model. So you can see that both of them are grooming themselves. They're whisking or moving their whiskers in their cage, which shows that they're happy in their environment. So they do well after the procedure. We have about a 95 to 98% survival rate. After we developed our model, we wanted to look at the health of the eye. Intraocular pressure is a measurement of the health of the eye. For example, it's elevated in diseases such as glaucoma. We compared naive rats to our transplanted eyes, and you can see that the intraocular pressure was within normal range. We then used optical coherence tomography, a non-invasive imaging technique, to look at the structures in the eye. And again, saw relative maintenance of gross integrity. You can see here, there are some opacities in the lens, which are likely due to ischemia or ischemia reperfusion injury. This is an example 1 week after transplantation, where you can see you can delineate the layers of the retina. We also then wanted to see if there was in fact blood flow in the transplanted eye after transplantation. So we did Doppler OCT, and you can see the red and blue structures are the blood vessels with in vivo real-time blood flow in the retina. But we then want to look also at the microcirculation in the retina, the smaller vessels. So we did fluorescein angiography. And you can see here, we have a naive rat and our negative control, the cut central retinal artery with no reperfusion. And then our transplanted eye. So you can see, although it's a little delayed, that there still is reperfusion and restoration of the microcirculation of the retina. We then did histology to look at the structures in the eye, in particular the retina. Just a little review, the retinal ganglion cells are the cell bodies of the optic nerve, and they send a signal from the retina to the brain to create a visual image. So looking at the retinal ganglion cells, 6 weeks after transplantation, when we compared naive eyes to a transplant, you can see that they're present in our transplants, but they're decreased in number, and there is thinning of the retina when you look at total retinal thickness. And this is expected because we've not yet introduced any interventions to help maintain the retina. So currently, we are looking at retinal cell preservation techniques because obviously during the procedure, they undergo injury from cold ischemia, warm ischemia, and reperfusion. So we have partnered with one of our collaborators at the University of Wisconsin, who has created a modified UW solution, which has been shown to decrease injury to the eye during ischemia time. And we have used this modified solution in some of our transplants. We also have added some inhibitors to our modified UW solution to target apoptosis and necrosis of the retinal ganglion cells. And these studies are ongoing. We are also partnering with Dr. Chen at the Shepens Eye Research Institute at Harvard. She has a protocol where she is introducing electrical stimulation to the retina and optic nerve of small animals, and she's seen neurite growth or growth after the electrical stimulation. So we're also going to use this technique as a way to preserve the retinal ganglion cells during the ischemia time. So of course, the question that I always get, can the rat see out of the transplanted eye? We used manganese enhanced MRI to look at the functional integrity of the retinal ganglion cells after transplantation. Retinal ganglion cells can uptake manganese and transport it in the axonal tracts. And we inject it intravitreally into the eye prior to doing the MRI procedures. We did this on 7 rats, and you can see the MRIs here. This is an example of one. So on the native side or the non-transplanted side, you can see that there's uptake of manganese, and it goes all the way through the visual tracts to the superior colliculus or the visual centers in the brain. And you can see in the transplant, it stops shortly after the retina, and you can see that's probably at our nerve apposition site or the site where the nerve is sewn together. But what this did tell us was that we did have some uptake of manganese, so there is some significant functional viability in our retinal ganglion cells after transplantation. So this in the future can be used as a way to detect functional return after transplantation. We also use electroretinography, where you introduce an electrical or light stimuli to the native and transplanted eyes. And you can see that in the native eye, this is the side that is not transplanted, you can see a normal action potential electrical response, and compared to the transplanted side, that it is very small. So in the answer to can the rat see out of the transplanted eye, the answer is not yet. But this is expected because we have not yet introduced any neuroregenerative therapies. So some of the strategies that we will introduce as far for neuroregeneration, one strategy is to place FK506 or tacrolimus onto our optic nerve apposition site. This has been shown to have a protective or neuroprotective effect on retinal ganglion cells after injury. We have created a FK506 nerve wrap. This is actually currently just patented, and this is been in the works for about 6 years. But we will use this to put around a nerve apposition to provide some neuroprotection for the optic nerve during the regenerative phase. One of our questions was also, how will rejection look in the setting of whole eye transplantation? The eye has typically been thought to be immune privileged or protected, but that's really only the anterior part of the eye, or which includes the cornea, because it doesn't have a lot of vascularity. But nobody knows really what will happen in the setting of whole eye transplantation with the entire eye. So we wanted to come up with a staging system for rejection. We also wanted to know, how will we diagnose rejection after eye transplantation? So we performed 3 groups with allogeneic, syngeneic, and naive transplants. We then performed our whole eye transplantation surgery, but we did not give them immunosuppression. And then we looked at gross morphology, histopathology, and some different modalities to look at rejection. So first, we wanted to look at the cornea, because it's the most easily identifiable part of the eye to look at rejection. We used some rejection scales that are already established from corneal transplantation. So we assessed our rats. If you can look at the syngeneic transplants, the cornea is transparent, but compared to our allogeneic transplants around postoperative day 5, you can see that it loses some transparency. We used the grading scale again with our allogeneic transplants and started to see a significant difference between our allogeneic and syngeneic transplants around postoperative day 4. We also looked at corneal thickness. Corneal thickness, again, is a sign of rejection. And you can see around postoperative day 6, there's a significant increase in our corneal thickness. We also wanted to look at the skin histopathology, the skin surrounding our eyes. And we used the Banff classification, which is already an established classification system in vascularized composite allotransplantation to look at skin rejection. So we compared, again, this is one of our allogeneic transplants, but we compared it to our syngeneic transplants and looked at the rejection of the skin. And usually around postoperative day 5, we would see significant rejection. We then perform ocular histopathology to identify cellular infiltration and inflammation. We use MPO, which is expressed in neutrophil and granulocytes and monocytes. We stained for that to look at components of the innate immune response, and also looked at the adaptive immune response. You can see again with the syngeneic transplants, there really is no sign of rejection. This is up to postoperative day 8. But then looking at our allogeneic transplants, several showed inflammation at postoperative day 2 in the choroid and limbus and peripheral cornea. And then we started to see inflammation in the central cornea about postoperative day 4. And then some retinal inflammation and showing no more CD3 positive cells at postoperative day 5. And then hemorrhage, apoptosis, and necrosis. So this is just an example of one of our allogeneic transplants. You can see at postoperative day 5, more positive CD3 positive cells. We also use RT-qPCR to look at 85 rejection-related genes. And again, with our allogeneic transplants about postoperative day 5, we saw an upregulation of about 64 out of 85 genes for rejection. And then also looking at serum cytokine and chemokine profiles, CXCL10 serum levels rose at around postoperative day 4, and interferon gamma around postoperative day 5. So from this study, we learned the immune response after allogeneic whole eye transplantation was a combination of acute innate and adaptive immune responses, and which were cellular mediated immunity and antibody mediated immunity, which both happened early in eye transplantation. It appeared that the blood retinal barrier potentially blocks cell infiltration in the early phase of inflammation, but breaks down after T cell accumulation into the graft. Some measures that can be used for early rejection include corneal transparency, as well as looking at increased serum levels of CXCL10. So these can be good markers of early rejection as opposed to skin histology and corneal thickness and serum interferon gamma. Those are not as good markers for early rejection. So after we kind of established a grading system for rejection, we wanted to see if the eye could survive with systemic immunosuppression. So we just gave our rat systemic tacrolimus, and you can see that there's pretty much maintenance of gross morphology. You can see some irritation around the eyes, but this is just because we sutured the eyes shut after each procedure. So next in our translational pathway, we've done some preclinical studies, primarily in primates, just looking, these were chosen because they have a high visual acuity. Their central visual pathways are similar to humans. They can be trained to report visual tasks, and their cranial anatomy is similar to humans. So we started to do some studies, just some simple biomimetric studies looking at the morphology of their globe and their bony orbits. We also did some studies to look at different ways to look at the perfusion of the eye in primates and of the cranium and the ocular tissue. We also have a collaborator that has a way to look at high definition fiber tracking to non-invasively visualize the recovery of optic tracts after injury. And lastly, in our translational pathway, we've also performed some human cadaveric studies. This part of our research is called Thea, or total human eye transplantation, because ironically, Thea is the Titan goddess of sight. This is included in a multidisciplinary team, including neurosurgery, plastic surgery, otolaryngology, and ophthalmology. So we used 8 preserved human cadaveric heads. They underwent the donor procurement and recipient procedures. These were globe and periorbital only transplant models. The neurovascular pedicle lengths and calibers were measured. So this is just showing our donor procurement procedure. So we made a terional craniotomy, so a partial craniotomy to approach the globe from above. And then we did an endoscopic procedure to decompress the skull base. So the videos showing us approaching the skull base and approaching the carotid artery, the paraclival carotid artery, as well as the optic nerve. So at this point, we're starting to decompress the optic nerve in the video, you can see there. And then after that, we cut the optic nerve and also cut the paraclival carotid artery. And then we harvest the globe. So you can see there, the arrow is pointing to the optic nerve. And again, we included a cuff of the internal carotid artery. This is really important because it actually added to our pedicle length, which makes it easier to perform the microsurgical aspects of the procedure. So this is our recipient procedure. So we thought about options of where to sew into as far as our vascular anastomoses, and we chose the facial artery and vein. And these are the blue structures above, those are vein grafts. So presumably we would do vein grafts to the intracranial portions in order to provide perfusion to the eye. And then we inset the eye. And then the procedure, let me show this video again. The video is showing from above from our craniotomy. That's me sewing the optic nerve together. So this would be just an example of the recipient procedure. So from this, again, the important parts included the measurements that we took, including the cuff of internal carotid artery, and that added pedicle length to do the procedure. And this is the timing of all the different components of the procedure for the donor and the recipient. And this will serve as a benchmark for optimization of the technique, introducing the possibility of vision restoration transplantation surgery. And again, these studies are ongoing. Our collaborator currently moved to Stanford, and we're doing more aspects of this study where we look at just more technically difficult procedures, like including part of the surrounding bone surrounding the eye. So we're currently doing that right now. So lessons learned: eyes can be transplanted and maintain gross morphology, their aqueous humor dynamics and perfusion. They can be maintained on immunosuppression without rejection. The surgery in humans is technically feasible. Of course, optic nerve regeneration remains a challenge, but much progress has been made. So I do get letters often from people requesting to be candidates for eye transplantation. This is part of what keeps me going, doing this research. So this is an example of one. Dear Dr. Washington, I'm a former Army Explosive Ordnance Disposal Technician. An undiscovered IED detonated and took both my eyes while I was diffusing another. I've only just recently read of the research you and others are doing in the field of whole eye transplantation. It is my sincerest hope to become a possible candidate when human trials become possible. And another one, most recently: Dear Dr. Washington, I am an Iranian living outside of Iran, worrying about protesters in my country. The forces have been using fouling pieces targeting the head, face, and eyes of young protesters with their guns. So there have been many cases where doctors had to take the whole eye out due to the level of injury. I've been feeling very helpless and seeking advice to see whether there's any hope for these young protesters who lost one or both eyes. Learning about your research has brought hope into my heart. Best regards. So I want to thank all of my supporters for the work that we do, and especially in my laboratory. Thank you to everyone in my laboratory. This is very extensive work, and I really appreciate everyone's time today. Thank you.
We have time for a question. Dr. McIntyre.
I know your ERG data is like your holy grail, and I'm wondering how you chose the time point in which you measured those. And the second question is, can you tell us just a little bit about the regulatory environment to work?
So for those online, time points for measuring rejection and regulatory issues with primates.
Specifically
The ERG, the time point, so I only showed one time point there. We actually do multiple time points. The beauty of ERG is that it's non-invasive. So the time points we chose, we did it at 3 weeks, I believe 7 weeks and 12 weeks. The 3-week time point I chose just because that's when all the inflammation goes down. It usually takes a couple weeks for the inflammation to go down after the surgical procedure. And then the rest of the time points I mostly chose just because 12 weeks is considered like a long-term time point for nerve regeneration in a rodent. So I just wanted to do those time points up to the long-term time point. As far as the primate work, that was actually done at the University of Pittsburgh. We don't have a primate facility here. Because the work that we did thus far is all non-invasive, there actually wasn't, they already have a well-established protocol set up, so there wasn't, a lot that I had to do as far as jumping hurdles to get that done. If we got to the point where we were doing procedures, and that would be a different case, obviously. We only did dissections on just, cadaveric primates so far for the procedure. So we actually did find that there was a little bit of a difference in the anatomy, which is why we kind of shifted to just doing human cadaveric studies, and then kind of just trying to optimize other non-invasive techniques to look at the primates.
So we're at time, but 2 quick questions or comments and 2 quick answers. Dr. Kovacs, Dr. Del Chiaro, and then we're done.
Well, I'm intrigued by FK506 and the nerve graph. I've never heard of that. Why would I? I'm wondering if you know anything about the mechanism of FK506 suppressive. Is it T cells trying to destroy the nerve ending?
I will say I don't know the exact mechanism of that. The only thing I do know is that the retinal ganglion cells have a FK binding protein, binding receptor, which appears to put kind of the nerve in a neuroprotective state, in a pro-regenerative state. But I don't know if that is actually related to the suppression of T cells. I think it's just the neuroprotection is actually not necessarily due to the immunosuppressive effect, but more due to the fact that it binds to this receptor.
One thing, I share your conclusions on all regarding activity as well as the nerve.
Mhm, mhm.
So where does optimism come from? So what do you think are the next step that could potentially optimize this space? Clearly, many areas of transplantation remain a big
Okay, yes. So the question was about the work that's been done in optic nerve regeneration. So I didn't get to show that just because of the timing for this this presentation. So, that's obviously a whole field, and we have collaborators, mostly at Harvard, who have, done some things with viral vectors and looking and alternating genetics in order to put the nerve into the pro-regenerative state. And they actually have had success in optic nerve crush models, and they've actually gotten some functional return of vision. So that's kind of where this has been ongoing for probably the last decade, where there's been some advances. So that's why we are optimistic. I do think it will happen in my lifetime, is what people say, as far as eye transplantation. So I think, it's a lifelong project for us, obviously.